Hi, I think we're going to get started. I'm just going to start with some announcements. First off, you're in ICD coding, increase your knowledge and income. Please remember to turn off all your electronic devices to silent mode. If you're attending with a young child, please use your discretion. We ask that you try not to disrupt another's learning experience. Posters on the Move is open from 7 a.m. to 7 p.m. Today is the final day. Tomorrow is the business meeting breakfast from 8 a.m. to 9 a.m. Tickets are required. Join us Saturday at 6:30 a.m. for a Zumba fundraiser. Sign up now at the registration desk. I am honored to introduce Dr. Joanne Sirota. She is a co-owner of Ambler Pediatrics, a private primary care pediatric practice for more than 30 years. She has been a preceptor for pediatric nurse practitioners for more than 25 years. Currently, she is adjunct clinical faculty at University of Pennsylvania, Drexel University, Gwen and Mercy University, and Villanova University. Joanne has presented at NAPNAP and AANP national conferences on such topics as practice ownership, technology in practice, and dental issues in primary care. She's a past president of NAPNAP, current president of NAPNAP Foundation, previous editorial board member of the Journal of Pediatric Healthcare, and currently the journal's corresponding editor for primary care case studies. She's a member of the advisory panel for Kids Health Matters Ready, Set, Grow, NAPNAP's consumer publication, and has authored several articles. I am also honored to introduce her husband. Dr. Fred Sirota is a graduate of the Temple University School of Medicine, completed his residency in pediatrics at the Children's Hospital of Philadelphia, and is board certified in pediatrics. He is a voluntary participant in the American Board of Pediatrics Maintenance of Certification Program. He also received subspecialty certification in pediatric hematology and oncology. Certification required 3 years of specialty training in pediatrics after obtaining the MD degree, followed by passage of a 2-year stage examination conducted by the American Board of Pediatrics. 3 further years of training in hematology and another examination was required for certification in hematology and oncology. In addition, Dr. Sirota served as an attending pediatrician at the Children's Hospital of Philadelphia for 8 years before entering private practice. He's a clinical associate professor in the University of Pennsylvania School of Medicine and also a graduate of Temple University Law School, receiving an LLM in trial advocacy, specializing in patients' rights. That's a lot, so welcome.
Isn't she funny? You know, we've been married for 35 years, and probably we're still married for 35 years because we never see each other. So, hey, it pays. Now, I always get nervous talking in front of people, so please, if I have to read some of my notes, look at this thing. I have to read some of my notes to stay on target, so just bear with me, all right? All right. Well, good afternoon. It's nice to see everyone here on Friday at 3. I think if it were me, I would probably say, where's happy hour right now? But thank you all for coming. I hope that when you leave that we clarify some issues for you, all right? So let me begin. Good afternoon. Dr. Sirota and I will be presenting our viewpoints on effective coding strategies for private practices and clinics, all right? We are not coding experts. I don't have a degree yet in coding. I don't think I ever want one, but I don't have one. We have owned our own practice. We started it from scratch in 1983, and we're still in practice. Nobody owns us. It's like a mom and pop shop practice, and we enjoy it very much. But we'd like to inform you about our experiences with all kinds of billing, especially these crazy ICD-10 coding changes, which have driven all of us crazy. All right, so we don't receive any money from anybody. I wish sometimes we did so we could retire, but no, we don't have any outside financial disclosures. Learning objectives today, of course, I'm going to review the history of coding, understand the need to keep current on coding, learn, hopefully give you some inside tricks on billing strategically, and also to explore with you the current ICD-10 changes. So what is the International Classification of Diseases? Well, it is a standard diagnostic tool for epidemiology, health management, and clinical purposes. It is now maintained since 1948 by the World Health Organization. The ICD is designed as a healthcare classification system providing a system of diagnostic codes for classifying disease, including the classification of a wide variety of signs, symptoms, abnormal findings, complaints, social circumstances, and external causes of injury or disease. It's a very complex system. It also monitors statistics for morbidity and mortality. It also is starting to monitor your statistics for reimbursement, which is really an important thing. It also has, I changed my page here, automated decision support in healthcare. And when I typed this on the slide, I said, what the devil does that mean? Well, it means that the ICD ensures, what this does is ensure timely attention to patient needs in the right clinical setting at the lowest possible cost. So when I submitted this abstract, I said, I know nothing really. It's been a long time since I was in school learning about the history of the classification of diseases. So I thought, maybe I would like to just review with you as to how this all started. And what I'd like to do is highlight some of the early pioneers in the classification of diseases. There were many, many individuals involved with this way back when, but I just picked a few people that I thought had more influence than others. So the London Bills of Mortality were the main source of mortality statistics designed to monitor deaths from plague from the 17th century to the 1830s. They were used mainly as a way of warning the public about plague epidemics. This information was collected by parish clerks. Now, this all took place in London, and the parish clerks, I don't know, each area of London had a church or whatever, and the clerks would gather the statistics about the deaths in their particular parish, and they would get together and publish these every week. John Gaunt noticed that certain phenomena of death statistics appeared regularly. He was inspired to write his book, The Natural and Political Observations Made Upon the Bills of Mortality, which analyzed the mortality rolls in early modern London that attempted to create a system to warn on the onset and the spread of bubonic plague. So this is the beginning of epidemiology. William Farr, though, was the first medical statistician. Farr developed the first national vital statistics system and developed the concept of surveillance of diseases, which did lead to the development of modern epidemiology. Farr's endeavors to craft a disease nosology usable by statisticians and epidemiologists led to the creation of the International Classification of Diseases. The one person I really like to highlight is Florence Nightingale, all right? Now, Florence, one of her first books was, she wrote the notes on matters of affecting health, efficiency, and hospital administration of the British Army way back in 1858, which provided statistical evidence that showed just how much of the mortality was due to the conditions of the hospitals. The statistical data Nightingale gathered during the first 7 months of the Crimean War were later analyzed with the help of William Farr, Britain's foremost statistician at the time. Her statistical analysis of military death in war and peacetime enabled her to understand the health issues in the military health service. She realized that it was the lack of sanitation which caused most of the deaths, not the lack of food or supplies. Although Florence Nightingale is rightly acknowledged and highly venerated for her role in reforming nursing in the mid-19th century, she clearly deserves more recognition than she has received for revolutionizing nursing through her use of statistics. Her investigative statistical work led to a decline in many preventable diseases that occurred throughout the 19th century in the British military and civilian hospitals. Her pioneering use of evidence-based medicine became a powerful directive in garnering support from the medical community and the government. In 1891, the International Statistical Institute established a committee chaired by Jacques Bertillon to prepare a classification of the causes of death which distinguished between general diseases and those localized to a particular organ or anatomical site. The International Statistic Institute adopted the first international classification of diseases in 1893. This system was based on Bertillon's classification of the causes of death. In 1898, the American Public Health Association recommended that Canada, Mexico, and the United States adopt Bertillon's classification of diseases and recommended that the classification be reviewed, revised, and updated every decade. In the following years, Bertillon's classification became known as the International List of the Causes of Death and ultimately as the International Classification of Diseases. In 1900 was the first conference to revise Bertillon's classification. It established, as I had said earlier, the need to revisit, revise, and reformulate the classification. So let me back up just a little bit. In 1948, the World Health Organization assumed responsibility for preparing and publishing the ICD. And it was in 1949 that ICD-6 was revised or instituted, and this was the first time that the mortality and morbidity conditions were really analyzed worldwide. 10 years later, they were ICD-7, 10 years later, ICD-8. You can see some of the things that happened. And in 1975, ICD-9 was revised, and it was published in 1978. That was the beginning of ICD-10, which classified diseases into the chapters with up to 4 to 5 digits. And that's what we have been working with for the past number of years. All right? So now, of course, the powers to be have decided that they wanted to update again. So they met in 1994 for the adoption of the current revision. It took until 2015, actually this past October, for them to be implemented. So what are the differences between ICD-9 and ICD-10? Well, as you all well know, coding is horrific now. Well, because there's 19 times as many procedure codes. There's 5 times more diagnostic codes. It's alphanumeric instead of just numbers. And the order of the chapters has changed, titles have been renamed, and conditions have been regrouped, including mouse bites, what else was it? Snake bites, on which extremity, which finger. It is very detailed. It drives everyone crazy. I had to put a little humor here because this topic can be a little dry. Are there really benefits from ICD-10? Well, the powers to be say yes. Better data to improve decision making. That is to be seen because it's still relatively new. It enables more specificity for the detail and documentation that leads to improved clinical care. Those outcomes are still in the making. Enables better unification of patient acuity to better allocations of resources. We'll see. The fourth point is a repeat of the third, so I'm going to skip that. Improves protocols and treatment algorithms, and supposed to improve tracking of outcomes. More benefits. Enhances the definition of patient conditions, provides improved matching of professional resources and care teams, and improves communication between providers. That jury's still out. Affords more targeted capital investments to meet the practice needs through better specificity of patient conditions. What are targeted capital investments? I think that outcomes that some of our insurance carriers are looking for in the Philadelphia area, we're being screened on our asthma outcomes. And they're asking for our use of pulse ox, our use of peak flow or pulmonary function tests, our asthma action care plans. So that is what this second point is talking about, is what did you have to invest to improve your outcomes. Supports practice into the transition of risk-sharing models with with more precise data for patients and population. I think that one of the things that we've improved in our practice is more patient education, and for parents to leave with either an app or a website or even a paper information so they can leave with an appropriate follow-up. Professional enhancements of ICD-10 provides clear objective data for re-credentialing. Now, the physicians, I think, are more impacted by this than the nurse practitioners because they have to prove their re-credentialing through outcomes using your electronic medical record and use of ICD-10. So the maintenance of certification is now going to be based on your results and outcomes using the ICD-10. It supposedly improves specificity for measures of quality and efficiency of reporting, aids in the prevention and detection of healthcare fraud and abuse, which probably initially there were lots of glitches as this was inaugurated back in October, and we're still finding a few issues with regards to reimbursement. Fraud and abuse I haven't read anything about, but reimbursement's been an issue. Provides more specific data to support physician advocacy, and I wanted to put a provider advocacy there for health and policy. Financial benefits. Better documentation of patient complexity and level of care supports better reimbursement for care provided. And I think that what we have seen in our practice is that if I see a patient that has more than one condition, my documentation has to be specific, it has to be detailed in order to get to upcode and to get reimbursed. So financially, I think that if I see a child that has an ear infection, pharyngitis, and a URI, and I hit all three systems and document that, I can go from a 99213 to a 99214, or if I do a throat culture. So if they have pharyngitis. So I think that that has enabled us to code better and to increase our revenue. Provides objective data for peer-to-peer comparison and utilization. The insurance companies are using this. And reduce the audit risk by using diagnostic codes with a greater degree of specificity supported by clinical documentation. I had just talked about that. And the codes are driving you nuts. I'm sure you're all aware that if you have otitis, you have to say right, left, bilateral. Is it suppurative? Is it it's whole 9 yards. It drives you crazy at the end of the day. Oh. And at this slide, it's my Dr. Fred Sirota's turn. Yes. I'm off the hot seat right now, and he will carry on from here. Dr. Fred Sirota.
Hi, guys. Well, if Joanne's talk could be subtitled the who, what, where, why, and when, this part is going to be more like subtitled like, are you kidding me? What I thought I'd do is tell you the story, our story, of how we got everybody in the office ready for this, what we had to do, what our experience over the last six months, 2 weeks and 5 days has been, some of the problems we've run into, the workarounds we've come up with, and what we think are going to be some of the problems in the very near future. Most of the preparation for ICD-10, the heavy lifting, if you will, was really done by our vendors and the insurance companies. You know, just about a year ago, a little after last year's meeting, things started to heat up, and we started to get notices that October was really going to be it. They weren't going to put it off for another year. We'd better get ready. And we would get emails almost every day about classes, about online coding courses, about services that were available. People were really trying to make a living off of all of this. It kind of reminded me of what happened when the computers went in December of 1999 to January of 2000. Everybody predicted that the sky would fall, and miraculously the computers clicked over that January 1st morning and everything went fine. And that's sort of been our experience here. Really, all we had to do, except get nervous about this, was be sure that our vendors had issued to us their latest updates, which included all the ICD-10 codes built in, and that they had tested with the clearinghouses, which they were responsible to do, and that the local insurance companies assured us that they were ready to go. The only thing that really scared me a little was when some of the powers that be suggested that all practices, even small ones like ours, had 6 to 9 months of income in the bank just in case the insurance companies glitched and couldn't pay. So that had us a little nervous. But one thing we realized is that even though this coding book is god-awful, I mean, god-awful, and this is just pediatrics, we realized that we really only needed to learn something about, if anything, about our little piece of the pie. In other words, in general pediatrics, we only really had to get familiar with some of the outpatient codes. These orthopedic surgeons had to know orthopedic surgery. The people in the nursery had to know neonatology, but we didn't have to really be bothered with that. And if you really looked at just the pediatric stuff, the AAP offered a little kit which included ICD-10 coding, and I don't work for the AAP, God forbid, but this is really something you guys should have on your shelf. But if you bought their coding kit for 2016, along came, miraculously, a super bill which included 90% of the codes that we use every day. And so between our vendor having updated our program to the point where all we had to do sometime in September, the end of September, was click on a little box that said generate the ICD-10 codes, the program itself really generated all the one-to-one codes. Now, what do I mean by that? I mean, most of the codes in ICD-9 have an equivalent code in ICD-10. There are some codes, and I'd say that's probably 80 to 90% of the codes. I may be a little off on that number, but there are maybe 10 to 15% of the codes that have more than a one-to-many, where there's, for instance, otitis, Joanne mentioned, where it was acute otitis, now you had to have a code for right, left, bilateral, acute, chronic, suppurative, non-suppurative, et cetera. And that makes it a little more complicated, but all of those codes are really on here. And if you think about it, there are really only about 20 codes you use almost every day, every week, commonly. And anything beyond that, you probably had to look up in ICD-9 also. So we clicked the box, the computer spun wizard, and all of a sudden we had codes, and it knew to use the new code starting October 1st for all transactions on that day forward, and to use the ICD-9 codes for all transactions before October 1st. And that's still true. If you're, although we're 6 months out, they may dishonor anything that's out that long. If you're really billing for anything that happened before October 1st, you still use the old codes if you're appealing or whatever. Initially, we kept it simple. You know, the old keep it simple, stupid. And we figured that we would really just use the general code for a specific illness. For instance, again, otitis, we would use acute otitis media bilateral and not hassle it for right now. And actually, we heard by way of the grapevine that the Center for Medicaid had informed the insurance companies that they should do the same, that they should keep their edits, very simple initially and not too critical, just to be sure that everybody's systems were working. And although I had heard that, read it, filed it away in the back of my head, it really came back to haunt me later, and I'll get to what I mean by that. So we held our breath, and that first week we send out our bills on Wednesdays and Saturdays after hours, excuse me. And out they went that first Wednesday night, and nothing happened. They went through, and we waited and waited. No big deal. We did it again on Saturday. Out they went. No rejections that we had noticed. Didn't hear anything. Got our 999 reports, which indicate that the insurance company received it. So they got to the clearinghouse and got to the insurance company. I said, wow, this is just too good to be true. We went on for about 2 or 3 weeks like this with no rejections at all. Everything seemed just swimming. We were just amazed that the sky didn't fall, the computers didn't fall apart. And sure enough, the checks started to come in and we started getting paid. I said, oh, this is like rolling off a log. I can't understand what everybody was all upset about. Well, about mid-December, we got our first rejection for a code for serous otitis media that our local Medicaid insurance company, Keystone Mercy, or Mercy, in the Philadelphia area, rejected. And we said, that's strange. Well, we look and we see the code was correct. The claim was correct. We couldn't find anything wrong with it. We recoded it as acute otitis media suppurative, and sent it again, and they paid it. Lesson number 1. You know the old saying that all politics is local. Well, all billing is local. And the first lesson is that just because there's a code doesn't mean you're going to get paid for it. And you really need to know what your insurance companies are set up to pay. And you need to keep track of how much they're paying. Now, I'm not advocating necessarily that you don't code correctly, because to do so would be a HIPAA violation. You know, it's part of HIPAA, it's part of the Obamacare Act as well, that ICD-10 be used exactly correctly. However, if you're in a position where you use the correct code and don't get paid, or you finesse the code a little bit and do get paid, I'm not sure that there's much choice there. Now, right after that happened, we contacted the insurance company and said, well, what's going on here? Why aren't you paying this code? And they did a little digging, a little research, and sure enough, they had updated their systems so that they now did. So lesson 2 is that your target is a moving target. And not only do you need to know what your insurance companies are accepting today, but you need to be sure they still are next week. Now, our billing software keeps track of exactly how much each insurance company is paying for each code. So I can go in and look for Group B strep pharyngitis and tell you what Aetna paid us last, what Blue Shield paid us, what Keystone Mercy paid us, etc. And you can compare, and those numbers can be vastly different and for the same code. But you need to kind of keep track of that and be sure that your charges are at least what they're paying. Now, you know, there's a lot of criticism in the industry, in the news, whatever, that doctor bills are not transparent, that hospital bills are just out of sight, out of reach. But what people don't realize is that we don't set the payments. We may bill for whatever, and the insurance company pays what they choose. And your only recourse really is to appeal, which gets very expensive in itself. So all I'm saying is that if they will only pay you 40 to 50 cents on the dollar anyway, you want to be sure at least that you're charging 60 cents on the dollar or 70 cents on the dollar. You just want to be sure that you're a little above what they're willing to pay, so that if they increase their payments 1 to 2% per year, you're not undercutting your own efforts. Okay. Now, A little bit about the coding, because we realized then that while we were coding for just one line item, that the insurance companies were going to start tightening up their edits. And in fact, they did. We learned this the hard way by billing for a child who had a cough. If you remember in the old ICD-9, you could bill for symptoms when you had no other definitive diagnosis. ICD-10 makes that a little tougher. They will not pay you for simple symptoms if there is an underlying disease as well. They want you to put on the first line pneumonia or asthma or whatever the reason is, URI perhaps, on the second line of the claim what the symptom is. If you look at the codes, this is very interesting. Just a slight digression here to explain a little bit of a bird's eye view of how this really is structured. If you get past all this nomenclature, which is really, I think, just meant to obstruct, what you're really told is that they prefer that you go to the coding book, which is split into two halves. The first half is an alphabetical index. I know you can't see this, but if you look in the code, it's an alphabetical index by disease state, which refers you to a section in the second half of the book which has the code number. Now, that would be the category, or the alphabetical, well, let me see, I'm confused here. Let's go, maybe go to the next slide. How do I do that? What do I push? Page? Okay, so what you need to do is begin with the alphabetical index, take that reference to the tabular list. Codes from the index alone in the front part may not be complete, but there are small notes in the fine print, both in this alphabetical index as well as in this tabular list in the back, which explain the code and what more is required. Okay. There are codes. A couple other points I just want to make about this. You would think it would be nice that the infectious diseases would be under I. In other words, the first letter is the alphanumeric. Better yet, let me, I think, right, oops. Going the wrong way here. I just did it, huh? Wait a minute. How do you? It's not a touch panel. I'm good. We're here. Thank you. Okay, here we go. Okay. The code is structured, the complete code that you're looking for is structured as a 3-dot. Oh, that's good that I can see the next one. Thank you very much. 3.4. The 3 part starts with a letter, and that letter puts you in the right chapter, the right area, the right disease section. And it would be nice if infections were I, if orthopedics was O, if pulmonary was P, but it's not like that. And in all honesty, I can't glean any kind of organization from it at all. But you can sort of figure that strep pharyngitis, MRSA abscesses, pneumonias are otitis media is in the infectious section, except it's not. Otitis media is in the ENT section. So you kind of have to learn your way around and kind of figure out where things really are. They may not be in the chapter that you think. Now, the first 3 X's, the first 3 places, have to be complete to be a code. And that may be a complete code unless the powers that be deem that you need further information. So the next 3 places, 4 through 6 characters, have to do with etiology, severity, site, certain manifestations, or in the case of an accident, was it intentional or not? So they really get into the nitty-gritty at that point. The seventh character is kind of special in that it may indicate which episode of care it is, whether it's the initial visit, a follow-up visit, or whether it has to do with sequelae of what happened. So the seventh character is necessary even if there aren't 4th through 6th characters. And if there aren't, only a computer geek would understand this, you need a placeholder so that the 7th character, the computer knows that the 7th character is in the 7th place, not in the 4th place. So you could have a code with A something something dot something 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 A at the end for an acute episode, for instance. Okay. So that 7th character, again, initial encounter, a subsequent encounter, sequelae, or for certain specialties like orthopedics may have special meaning. Okay. Now, this just seems like, oh my God, are you kidding me? I mean, think about it, really. You have a 15-minute visit, right? A lot of practices will even have 10-minute visits. In 15 minutes, I just jotted down a few things here, what you're expected to do in 15 minutes. Okay, you open the door, you're supposed to schmooze. Hi, how are you doing? How's little Johnny today? Get down on the floor and play for a minute, right? Schmooze. You're supposed to get an interval history. You're supposed to screen for autism, depression, school problems, drugs and alcohol, developmental screening. You're supposed to reconcile their medication because NCQA wants to know that you did that. You're supposed to do auditory and vision screening, counsel on, remind them to use their helmet, their seatbelt, and their condom, and screen for lead exposure in the small kids. Then you go out to the front, at least in our case, we go out to the front desk, write a beautiful note that will hold up in court, and be sure you've coded exactly correctly. Otherwise, you're in HIPAA violation, right? Cut me a break. Okay. Now, to make it even worse, I found this little tip. Part of the this bundle you get from the AAP is a monthly newsletter. It's very nice, very authoritative. Comes from the Academy of Pediatrics. Not quite as authoritative as NAPNAP, but. And one reader wrote in, it said, what diagnostic code would be appropriate for the management of a tick bite to the right axilla? The tick was removed, antibiotic prophylaxis prescribed for Lyme disease. The Academy of Pediatrics says, tip. The diagnosis of tick bite can be difficult to find because there's no specific listing in ICD-10-CM. Index for tick bites, one might not know that ticks are technically classified as arthropods. Consulting the ICD-10-CM index for bite by an arthropod will lead to C venom, bite, arthropod. But a tick is generally considered a non-venomous arthropod. A little further study of the index indicates that the term bite indicates that the bite of a non-venomous spider, also an arthropod, is classified as a superficial insect bite according to the site of injury. This indicates that the bite of any non-venomous arthropod, such as a tick bite, is classified as a superficial insect bite of the specified anatomic site. Therefore, S40.861- with that last position being right upper arm, or right unilateral. Okay. So, what I suggest, the best way to handle this morass is, one, to get your common codes off the super bill. Have them ready to go so that your provider just needs to circle where you are. The codes that take more than 2 nanoseconds to find, we write on our super bill, and we leave them for our biller, who is not a certified coder, but has a few minutes to go looking up the codes that take a little bit more searching. So we're paying her $18 an hour to find codes, which should be easy to find. Wrong. Okay? The tough ones, like tick bites and things that you have to go dig for, she will keep track of. And gradually, we will build a second page to our super bill, which won't necessarily be put on each chart as it goes out, but rather posted on the wall so that when we don't have to search those a second time. All right. Third lesson, then. Keep a record of these hard-to-find codes. Now, with 6 months of data, it becomes important to start following your KPIs. Anybody know what a KPI is? I didn't. Key performance indicator. What is a key performance indicator? Well, you go to another one of these tricky handouts, and they give you, 20 of them. And they are, we should be keeping track of the days till we get our final payment. Days to payment. Claims acceptance or rejection rates. We should be keeping track of claims denial rates. And reasons. We should be keeping track of payment amounts, reimbursement rates, coder productivity, volume of coder questions, requests for additional information, daily charges and claims as a number of charges or claims submitted per day, edits by the clearinghouse, payer edits, use of ICD-10 codes on prior auths and referrals. Remember now, you send somebody out for an MRI or for a second opinion or to a specialist, you have to code the patient on that request now too. Incomplete or missing charges, incomplete or missing diagnostic codes, use of unspecified codes, how many of these are returned to the provider, and medical necessity pass rate. How many of those long letters you write as, for your patients that something is medically necessary, how many of them really get rejected? So the codes then can be a minimum of 3, a maximum of 7 positions. The 7th position special. The 4th, 5th, and 6th indicate additional information. Now, where we're going is that they also want this kind of detail for secondary, tertiary diagnoses. So if you see a patient, let's say, with autism who has a seizure disorder, who's had medication allergies, they want all of that on each claim. Okay, so the simple direction then is look up the condition in the alphabetical index, take it to the coding part in the back, the tabular list, be sure you read the fine print. It will tell you what other things you need. That's our super bill, you can't read it. And having done all that, just 2 weeks ago, we ran into a new problem. After sending out our statements one night on a Wednesday night, it just caught my eye that there was one claim down at the bottom where the software had indicated diagnosis error, DX error. Didn't even leave our computer to go out. So this is an error generated inside our own office, even before the clearinghouse, that there was something wrong with this code. And we called our vendor, and he basically yelled at us for having done something wrong, not sure what, keep track of it and let me know. So now every time I send a batch of claims, I look through that whole list after they're sent. I can sort and list just those that kick out as a diagnostic error. And we're finding errors that went back to November, that we had no notice of rejection from the clearinghouse or the insurance company because they were rejected by our own software in-house. So that's something new and different, a whole different dimension that we hadn't anticipated at all, is a bug in the software that's kicking out some of these codes. And so far, we haven't been able to find any rhyme or reason or anything common to any of these codes. All right, so in summary, remember that ICD-10 is international coding, but whether you get paid or not, whether these codes are recognized or not, is a local phenomenon. You have to know what your insurance companies are recognizing, which ones they're willing to pay for, and which ones they're not. Do you code the patient as having an upper respiratory illness or a viral syndrome? It makes a difference. They may pay one more than the other, and you need to know that. Follow the money. Insurance company reimbursement, you have to stay on top of it. and expect tightening. Whereas initially they took that one code for otitis bilateral without questioning, now they're smart enough to know that you're coding all of them as bilateral. That can't be true, doctor. Let's reject them all, have you review your chart and send them back. Which ones were right, which ones were left, which ones are bilateral. Now I ask you really there too. How many times do you look at a child who's screaming, has a temperature of 102, and has maybe an ear infection on one side that's unequivocal, big bulging eardrum, a purulent fluid level that you can see, extreme pain, and the other ear is occluded with cerumen. Now, you can either code correctly or curette the cerumen. What do you have time for? And that's all I got to say. I'm sorry? Questions? Please. Right. 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 Mm-hmm. 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 I'm sorry, you can't hear. Right. I can barely hear her. Right. I, I don't know that they have any way of knowing whether you're right or not. So you might want to factor that in. Anybody else? Please. I'm sorry, we can't hear. Well, I don't work for the insurance company, so I can't tell you what they're thinking. But I can tell you what I'm thinking they're thinking, which is that initially they started out lenient because CMS told them to do that to be sure that everybody's systems were working. Now they realize not only are the systems working, but Obamacare is costing them a lot of money. And so they're starting to tighten. And I think what they're doing is where everything Joanne said was correct. You know, it would be wonderful to be able to track ultimately what treatments work for what diseases, to be able to get epidemiologic data on all of these things, to find out how many times it's the right middle cerebral artery, okay? But the fact is, there are competing interests here. Your interest is in taking care of the patient as best you can. The insurance company's interest is in paying as little as possible for that as they can get away with. The government is interested in getting real statistics. And so my point is that there are three competing interests tugging at this. And I don't know where this is going to go, except that it looks like they're tightening up, tightening up, tightening up. And I think it's going to get just tougher. And because very soon, in the next 2 or 3 years at least, with affordable care organizations and the whole direction that medicine is going, they're going to pay for performance and not for anything else. And how are they going to judge performance but for the codes you're using and the outcomes for those codes? So if you code for pneumonia, they want to make sure that patient doesn't get hospitalized to be sure you're treating that patient properly as an outpatient. If they get a bill for hospitalization, then your performance is going to go down. So that's where this is going. They're going to hang us with these codes. I didn't say that. Oh, there are several. And my guess is go to your major insurance player will have in your area will have an app, and that will give you the bulk of the codes for that insurance carrier. Now, there are going to be updates, and what Joanne said is there's actually going to be an update to ICD-10 every year in October. So come October, there will be an update, and then expect your vendor, be sure that your vendor is updating. I know that the first person we send to, just total. Yeah, like Relay, the Relay, that their edits are changing every other week to 10 days. We get a little download when we go to open our billing module. It'll say there's an update. Download that, and it'll update the latest NCCI edits. So this is a moving floor going in all different directions for whether you're an insurance company or whether you're the provider or whether you're the software vendor. It's just murder. I'm sorry, say it. I have no idea. I think, again, I'm not them, but I think that they will use any possible means to reduce payments. You know, they judge us on whether we're a medical home. They judge us on whether we're computerized. They'll judge us very soon on outcomes. And they'll change the rules, and as the profession starts to adapt to it, catch up to them, they'll change them again. We see that with Blue Shield in the Philadelphia area, where they withhold about 20% of our payments and give that back to us as a bonus based on our performance in certain levels. Are we prescribing just generics? What's our hospitalization rate? What's our referral rate to specialists, et cetera? And so as we start to correct that and start to learn how to play that game, they change the rules, and they'll decide that next year they'll be monitoring different things. They'll be monitoring HPV vaccine, which they haven't up till now. They'll be monitoring your use of, Rototech. So the rules are changing, and if you're as cynical as I am, you tend to think that it's not about quality of care. What is quality of care?
They've even changed the rules in procedure. Application, schedule a pre-approved for an MRI. MRI, we're not paying for it.
Yeah, I think until the patients get some understanding of what's going on and rebel against what's being denied them because they're paying the policy, it's not going to be about patient care until then. Hey, thanks a lot. I'm sorry.